We're going to move forward now. We've heard a lot about surgical and transcatheter aortic valve replacement. And next, we're going to hear about aortic valve repair. Dr. Serna-Gallegos is going to talk to us about when we should do that or think about doing that. Derek.
Thank you. I want to just first thank all the directors of the conference and the symposium, Dr. Gata, Dr. Smith, and Dr. Sultan for having me. Today's talk, we're going to talk about aortic valve repair and when to do it. We're going to briefly talk about some aortic valve anatomy, advantages and challenges to aortic valve repair, some strategies for aortic valve repair, and then some results. The advantages of aortic valve repair can be, there can be many. Hemodynamics are obviously the best of the valve that we're all born with. Durability, we're going to talk a little bit about things that can make some valve repairs more durable than others, but generally, absence of calcification and absence of things like fenestrations can make for a very durable valve repair. There's really no chance of a patient prosthesis mismatch for our own aortic valves. It's the lowest endocarditis risk, and one of the main things that patients love is just the avoidance of anticoagulation. Especially as you'll see in the population of the aortic valve repair patients, it's generally younger patients, and being able to avoid anticoagulation for a longer part of their life is obviously quite the advantage. Isolated aortic regurgitation with essentially normal cusps is relatively rare. Tri-leaflet valve has 3 coaptation zones that all need to be optimized to maintain a good functioning valve that's durable over time. And often we see at least some leaflet calcifications or some fenestrations. And the more we have to do to any leaflet, whether it's decalcifying it or repairing things like fenestrations, the more complex it becomes and the worse the durability is over time. One of the things that's very important about aortic valve repair is thinking about it much in the same way that we think of mitral valve repair. We often think about the mitral valve and the subvalvular apparatus and all the different parts, the chorda tendineae and the papillary muscles and all the different functioning parts of the mitral valve, and we really need to think about the aortic valve in the same way. Manipulation of the annulus, manipulation of the cusps, the commissures, the intercommissural triangles that really give a lot of the support from the annulus and the ventricular aortic junction all the way up through the commissures, and the connection of those leaflet or cusps, the anchoring of them into the aortic wall. All those parts of the aortic valve are incredibly important, and manipulation of those is important for a good, durable aortic valve repair. The sinuses of Valsalva, we know, are so important in the durability of our own leaflets and being able to minimize the stress as the valve opens and closes during the cardiac cycle. The sinotubular junction, the alignment of the commissures, which allows for great coaptation of the leaflets and the cusps. All that is incredibly important, and we need to think about the aortic valve as a unit and the aortic root as a unit, and all those parts being incredibly important in the repair of the valve. So, noting those important anatomical structures, all of those can be intervened upon. Annuloplasties of the aortic valve have also been described in addition to as part of the repair. Same with cusp remodeling, although cusp remodeling, I think the more that you have to do in terms of central plications, triangular resections, and free margin resuspension of the cusps, the more complex that becomes, there is some decrease in durability. Raphe remodeling for bicuspid aortic valves, commissural resuspension, both in valve-sparing root repairs, and also very importantly, and one of the most kind of common aortic valve repairs that we do is aortic valve repair for aortic regurgitation and aortic dissection. And commissural resuspension is incredibly important in giving those patients a long-living, durable repair of that aortic valve. Sinus replacement, as in the remodeling technique, and resizing of the sinotubular junction, again, kind of realigning those commissures and making everything very competent. The two most common types of valve repair, I mentioned aortic valve resuspension for aortic dissection, but also valve-sparing root replacement. We're going to focus more on valve-sparing root replacement today, just out of time issues. So the requirements for the two techniques, reimplantation and remodeling. Reimplantation, you need absence of cusp degeneration. Remodeling, in addition to the absence of cusp degeneration, you need an absence of annular enlargement. Now, there's kind of a theory on the two different types of aneurysms and the repairs that you can do for both of them. So in a young patient with a genetic syndrome or genetic disease, Marfan's-Loeys-Dietz, where a lot of the pathology is down in the root, often you'll have annular ectasia, annular dilation. And that lends itself more to a reimplantation technique where the annulus is stabilized. Patients in their later decades of life, often patients that have degenerative, ascending aortic aneurysms that start in the ascending aorta and move proximally into the sinotubular junction, with that being and into the sinuses also, but with much of the pathology being in the ascending aorta and moving proximally, those patients can do as well with a remodeling technique, because the annulus is not as often enlarged in those patients. This is a picture of a reimplantation. For the reimplantation, the apparatus affected the annulus is stabilized, sinotubular junction is resized, and the commissures are resuspended. This was Tyrone David's 20-year data looking at reimplantations, 333 patients, follow-up of 10 years, mean age, again, 46 years, mostly young patients. The survival, 20 years, the survival all the way out to 20 years, just under 80%. If you look at mortality, or a combination of mortality or reoperation at 20 years, 22.8%, but very good results. If you look at the degree of aortic regurgitation, severe and moderate, 1.3 and 2.6% at 20 years. And then the graph at the bottom is mostly just to look at everything except for the very deep red is no aortic regurgitation, trace, or mild. So over a time period of 20 years, very, very few instances of severe or even moderate aortic regurgitation. This was 25-year experience of Tyrone David's group looking at both reimplantations and remodeling, mostly reimplantations and some remodeling. Mortality, freedom from mortality at 18 years, 76.8%, freedom from reoperation at 18 years, 95%, and then freedom from significant aortic insufficiency, 78% at 18 years. This is comparing their remodeling and reimplantation, not any statistical significance, but some trending towards freedom from reoperation being better for the reimplantation technique all the way out to 20 years. So if we're looking at remodeling, the apparatus that are affected, the sinotubular junctions resized, the commissures are resuspended, and the sinuses are basically replaced. Annulus is not stabilized. Some people do perform an annuloplasty in addition to the remodeling technique, which can have some added benefit of stabilizing the annulus. This is a picture of the way it's performed, and you can see that the valve is not reimplanted within a graft. It's the sinuses are replaced and the valve commissures are resuspended. You need an absence of cusp degeneration and absence of annular enlargement. This is a large group's data from Germany, almost 750 patients, mean age of 54 years. Freedom from reoperation was significantly different between tricuspid, bicuspid, and unicuspid valves, with tricuspid valves having the best freedom from reoperation. There was not a ton of unicuspid valves included, and the data did not go out as far as the others. Freedom from significant aortic regurgitation. They did have some changes to their technique. In 2009, they added that annuloplasty, which seemed to improve their freedom from aortic regurgitation. One last quick study from the same group, a 20-year period, looking at just root remodeling and bicuspid valves to see, can this work well for bicuspid valves? They had 97.8% follow-up, a mean follow-up of 57 months, ranged in age from 10 to 80 years. Reoperation was 12.3 at 10 years, 21 or 22% at 15 years, and significant aortic regurgitation was almost 20% at 15 years. Development of aortic stenosis with any cusp calcification was very low at 10 and 15 years. So which is better? They're both different, and I think that they should not be seen as competing procedures. Reimplantation, again, going back to the kind of thought that, you know, if it's a young patient, the pathology starts in the root and moves distally, then you need to make sure that you stabilize the annulus, and that would be an argument for reimplantation. For remodeling, if the aneurysm is more in the ascending and going proximally into the root, those patients can do well without annular stabilization, just with a remodeling procedure. So when do we do each repair? Well, you have to have non-calcified cusps with minimal need for cusp repair. Have to be an experienced center, metabolically appropriate, meaning it can be done in aortic dissection, very select patients that are going to tolerate a little longer operation. Thank you very much.